Hello everyone, Learning Insight welcomes you to today's new topic, leukemia. Leukemia includes AML, ALL, CML and CLL. AML is acute myeloblast leukemia, ALL acute lymphoblast leukemia, CML chronic myelocyte leukemia and CLL chronic lymphocyte leukemia. Here on the right side we have an image explaining the normal blood and leukemia disease blood. Normal blood is RBC, WBC and platelets in a normalized ratio, and in leukemia disease blood we have increased WBC and RBC and platelets are decreased. This is what is leukemia. Abnormal production of WBC cells, majorly the myeloblasts and lymphoblasts in the bone marrow. This is what is leukemia. To understand this myeloblasts and myelocytes or the lymphoblasts and lymphocytes, we need to understand hemopoiesis algorithm. So let's have a look. Are further divided into non-lymphoid committed progenitor cells and lymphoid committed progenitor cells. Non-lymphoid progenitor cells, we have myeloblast, monoblast, megakaryoblast, erythroblast, as you can see. Then myeloblast and promyelocyte and myelocyte. Myelocyte is granulocytes. Here we have the myeloblast and myelocyte. And the same thing here in lymphoid committed progenitor cells, you have lymphoblast and then lymphocyte. So let's see what is the etiology. There are many factors which are causing leukemia. So firstly, it's genetic factors. Down syndrome and Fanconi's anemia are the examples. Next is radiation, treatment of other diseases, other malignancies, as well as ionizing radiations through CT scans and X-rays, that can be the cause. Next is exposure to chemicals and cytotoxic drugs. Cytotoxic drugs could be as a chemotherapy for any other malignancy treatment. And hematological disorders, myelodysplastic syndrome and aplastic anemia. Next, this is a very rare thing, but viruses are also included as a cause for leukemia, especially the human T-cell lymphotrophic virus. So now let's go to the pathophysiology. Pathophysiology, here it is explained that the cells which are produced in bone marrow, they are getting transport to the blood after like accumulation, and those mature as well as immature cells, WBCs, RBCs, they are getting transferred to the blood, and from there into the they are getting infiltrated into the liver and major organs. So here we have the described form of the same thing. Increased WBCs at bone marrow, which is leading to reduced nutrition to the other cells, and this is leading to increased accumulation of the malignant cells, that is the abnormal dividing cells. Those are getting accumulated, and because nutrition is less, as well as other cells are also getting affected, and as such lymphocytopenia, anemia, thrombocytopenia, neutropenia are seen. Now when these cells from the blood, they get infiltrated into liver, spleen, myeloblasts get into liver, spleen, it is AML, and when lymphoblasts get into lymph nodes and tissues and spleen, then it is ALL. So here I thought I preferred to understand clinical manifestations to treatment in comparison, so that we can learn easily. If we learn anything in comparison, we can understand what are the differences and what is in common, so that's easier to learn. AML infection, anemia, bleeding, severe bleeding, disseminated intravascular coagulation, infiltration of WBC in major organs like liver and spleen, expansion of liver and spleen is showing hepatomegaly and splenomegaly. Similarly, in ALL you have headache, vomiting, lumps on skin, swollen lymph nodes, that is nothing but lymphadenopathy, and swelling in meninges. Hepatomegaly and splenomegaly is also seen. Diagnosis: AML and ALL. AML, we have genetic history which we the genetic cause which we saw in causes section. Next is physical examination, that is by symptoms, and peripheral smear, in that we see anemia, thrombocytopenia, and that is increased 60% in WBC. And next we see is microscopic blood examination, where the myeloblasts are seen as large cells but no nucleolus is present, and we have Aver nodes. Aver nodes is crystallized aggregates of myeloperoxidase enzyme. Myeloperoxidase enzyme also helps in staining, and as such we can find out what is the differentiation between myeloblasts and lymphoblasts. Flow cytometry is another analysis, and bone marrow biopsy. Biopsy is done to understand the extent of the severity of the leukemia. ALL, Still, peripheral smear, it's similar in ALL also. Lymphocytes are also increased, and in microscopic blood examination, small cells, lymphoblast are small cells with no nucleus, and here the DNA polymerase TDT enzyme helps in staining. Bone marrow biopsy is done here also, and flow cytometry is the same. Here we can see there are images explaining bone marrow biopsy, as well as it was a brief description of the diagnosis. So now let's see, how do we treat leukemia? What is the treatment? Pharmacological treatment. Here in ALL, firstly we'll see ALL, we have induction or remission therapy, where the drugs are daunorubicin, L-asparaginase, vincristine and prednisolone. Here we can also add methotrexate and cyclophosphamide, which are the cytotoxic drugs. In ALL, we have CNS involvement, that is convulsions, and the prophylaxis for CNS is cranial irradiation and methotrexate, which is given intrathecal. Next is maintenance therapy. In order to sustain the induction or remission therapy, maintenance therapy is given for 2 years. 6 MPV, this is the mnemonic, 6 mercaptopurine, M methotrexate, P prednisolone and V vincristine. Next is, there could be anytime any relapse of testicular relapse or bone marrow relapse of leukemia. So induction, that is intensive induction, and radiation therapy is being given. Next we'll see AML. Here we have again the similar things like induction and consolidation chemotherapy. The headings are similar. We have cytarabine, daunorubicin and thioguanine are the drugs. Next is the post-remission therapy, because it is like after the maintenance also, as well as when we have relapse, we can involve this therapy, that is intensive consolidation chemotherapy. And alternative to this chemotherapy, if we don't want this chemotherapy even in relapse, then we can go for stem cell transplantation or bone marrow transplantation. Next is Chlorabin. This is the drug which is given to old age patients more than 60 years of age, because it is effective and there are less side effects when compared to chemotherapy. AML also has acute promyelocytic leukemia, which shows DIC. DIC is disseminated intravascular coagulation. Actually, promyelocytes, they lead to extensive tissue factor secretions into the blood, which leads to coagulation cascade. Here it is treated by ATRA, which is all trans-retinoic acid, and this helps in maturation of all the cells, and hence promyelocyte will be forming into myelocyte, and there is no presence of promyelocytes. So this leads to death of the cells after a while, after a time period. Hence there is the increased WBC count, and also DIC is also decreased. This is the treatment. So here comes the end of today's session. Please don't forget to like, share and subscribe, and just stay tuned.